and I'm the training coordinator for Max and Max for Moms. I'll give you an overview of what we do at Max, but before we get started, I'll just give you a little more information about how to receive credit for today's webinar. We are offering CEUs and CMEs for today. If you are looking for CEUs, you do have to be on for at least 45 minutes to get full credit. We unfortunately cannot offer partial credit. And for both CMEs and CEUs, we will be sending out an evaluation survey from Qualtrics immediately following today's webinar. And that'll be going to the email that you registered with. You will also receive a copy of the slides, which will be in a separate email, and that will come out later today, but that will also go to the email that you registered with. And we encourage you to look out for those emails for that information, but also for more information about Max for Moms and how to get in contact with us, as well as an overview of the services that we offer. So Max for Moms is a part of Max, the Maryland Addiction Consultation Service, but MOM stands for Maternal Opioid Misuse. All of our services are completely free since we are a grant-funded program, and they include a warm line for clinical questions, and those can be as patient-specific as you'd like, as long as you call us with de-identified information, and we'll connect you with the appropriate consultant to walk you through the best way to treat that patient. Or you can call about general questions. Maybe you're not sure how to treat a patient who's pregnant and also has substance use disorders. Our consultants are happy to just give you an overview of how to prescribe medications to them and best practices. We also offer training similar to today's webinar. We try to do them during the lunch break to accommodate busy schedules. Another service that we are offering right now is we have a limited supply of doTERRA bags, which are used to safely dispose of medications. We are happy to send those out to you. We just ask that you contact Max for Moms. Trying to see if there's anything else. So look out for that contact information. We will also include that in the follow-up email immediately following today's webinar. And finally, I will give an overview of our presenter today. Our presenter today is Dr. Mark, who is an OBGYN and holds dual board certifications in obstetrics and gynecology, as well as addiction medicine. Her research and clinical interests center around the intersection of reproductive health and substance use. And she is the medical director of the University of Maryland Women's Health Center at Penn and the director of the Substance Use in Pregnancy and Parenting Outpatient Recovery and Treatment Practice, also known as SUPPORT. In addition to her obstetric practice, she has ambulatory gynecology practice at the University of Maryland, where she cares for people with gynecologic needs throughout their lifespans, and she performs gynecologic surgeries at the University of Maryland downtown and Midtown campuses, as well as the VA hospital in Baltimore, Maryland. Dr. Mark is a great example of a consultant you could be connected with. If you do call our warm line with questions, she's also on our Mom's Echo, and I can put more information about that into the chat. But Dr. Mark, I will turn it over to you. If you have questions throughout today's webinar for Dr. Mark, I will read them out when there is a break between slides, so just please enter those into the chat. But Dr. Mark, it's all yours.
Thank you. You can hear me okay? Sarah? Okay. I'm going to assume yes. Okay, so thank you for that introduction and for everybody that joined today. And today we're going to talk about obstetric care for the pregnant person with opioid use disorder. So Sarah already gave a very good overview of Max for Moms. And as she said, I'm one of the consultants and the services are always free. And we encourage you to use them as needed. So today we're going to talk a bit about opioid use in pregnancy, some treatment options. The goal of this talk is not necessarily to do a buprenorphine waiver training for everybody, but just give you a generalized overview. So if you're caring for pregnant people, you understand the different options of treatment and which ones are recommended in pregnancy. We're going to talk about considerations during prenatal care, some things that may be different for people who use opioids during their prenatal care than others, intrapartum and postpartum management, breastfeeding, and finally neonatal opioid withdrawal syndrome. So first, why do we care about this topic? As an obstetrician, I spend a lot of time treating things like high blood pressure and diabetes, and although those things are very important, in the state of Maryland, the #1 reason for death during pregnancy or in the year post-pregnancy is unintentional overdose and substance use. This graph is from 2017, but the numbers have always look very similar to this. And the most recent numbers in 2020, I think, it was 25 deaths in that year in the state of Maryland. So part of a comprehensive treatment plan for a person who uses opioids is medication for opioid use disorder, or MOUD. The goals of treatment with MOUD during pregnancy are to prevent withdrawal, provide a stable intrauterine environment, because the most harm that is caused to the fetus during pregnancy really is not from the medication or the drug itself, but it's from the unstable environment in utero and the constant cycles of withdrawal and use that cause increase in cortisol levels. And so really we're trying to prevent that, that cycle of withdrawal. There are also psychosocial improvements with MOUD, including improved mental health and more stable, housing, ability to come to care, things like that. And just overall risk reduction to decrease risky sexual behaviors, decrease risk of sexually transmitted infections, including HIV, decrease risk of overdose, and decrease risk of all-cause mortality. So I think it's important to keep this in mind when we're talking about pregnant people, because I remember being a medical student, and the first time I saw a patient on methadone, just thought, like, isn't this wild? Like, we're telling them they shouldn't be on opioids, but now we're just prescribing them opioids. But again, the biggest risk in pregnancy isn't actually the opioid. It's the unstable environment that has to do with people who are using opioids, both the withdrawal, but also just all of the other behaviors that come along with access to opioids and risky situations that they are exposed to. So when somebody uses opioids chronically, when they first start, they get this high or sort of euphoria. And then that is something that over time decreases quite a bit. And in fact, I just had a patient the other day that told me that she's always chasing that first high, and she's eventually realized that she's never going to get back to that level. And the reason is because your body becomes dependent on it and gets some tolerance, right? So over time, people spend less and less time in that euphoric or quote unquote high range. And really, they're spending a whole lot more time in withdrawal, and they're using to prevent withdrawal and make themselves feel more normal, as opposed to using to get high. So the purpose of their use really changes over time. And the purpose of MOUD is to keep people in that sort of normal asymptomatic range where they're not high, they're not withdrawing, they're just stable. And that's why this is only a part of the treatment for opioid use disorder, because the whole goal is to get the person to a stable medical place where they can then engage in therapy and other, wraparound services and care that that will help them in their long-term recovery. Unfortunately, there's a lot of stigma around MOUD, particularly in pregnancy. So a lot of people have the misconception, patients, family, everybody, that it's really just trading one addiction for another. And that is categorically not true. So addiction is a brain disease whose visible symptoms are behaviors. It is different than dependence. So a person can be dependent on a medication. And in fact, people do become dependent on their MOUD, just the same way that they're dependent on insulin or dependent on their high blood pressure medication, that their body needs it or it will have a response. But that's not the same as addiction. So with addiction, people are spending a lot of their time trying to get this drug. They're putting themselves in risky situations. They're using more than they intended to. They're having other like psychosocial consequences of it, which is not the same as dependence. And so taking medications for opioid use disorder is like taking medication to control any other chronic illness. And it should really be presented to the patients and the families in that way. And we should think of it that way as providers. So one of the hardest parts oftentimes of taking care of people with use disorders and addiction is just this sort of feeling that it's inevitable that they're going to return to use and that they're going to be, they're not going to be able to stay stable in recovery for a long time, which first of all, that's categorically not true. But second of all, there are going to be a lot of times when people return to use or have exacerbation of their disease. But that is really the same as any other chronic disease, right? If we frame it as a chronic disease, opioid use disorder or drug addiction in general has relapses and flares just as frequently, if not less frequently, than other types of chronic medical disorders. And so, if I need to increase somebody's antihypertensives or they get hospitalized for an asthma exacerbation, you don't view that as a failure, right? You just think that's part of the course of this disease. And drug addiction should really be looked at the same. Even though we wish that everybody would stay in recovery forever, the return to use is often part of the long-term cycle of the disease. So there are 3 different types of medication that can be used in general for opioid use disorder, and we're going to talk about these 3 medications and their use in pregnancy. So one is a full agonist, a full opioid agonist, which is methadone. Other full opioid agonists would be things like oxycodone, OxyContin, heroin, fentanyl. Those are all full opioid agonists. So they bind to the opioid receptor, and they have full expression of that receptor. Partial opioid agonists, the one that we use for addiction is buprenorphine, it binds to the same receptor competitively, so it pushes off the full agonists, and it only has partial expression though. So it binds to the same receptors, but it doesn't have as much effect on that receptor as the full agonist does. And then there are antagonists like naloxone and naltrexone, which completely block the opioid receptor. So all these medications work on the same receptor, just their expression or the what it makes the patient feel like, or the response to the binding of the receptor is different. So methadone is a full agonist. It comes in pill and liquid form. It can be started immediately. A person doesn't need to be fully in withdrawal to start methadone. It needs to be very slowly up titrated due to its long half-life. And it can only be prescribed or dispensed by licensed regulated facilities. So myself as an OB doctor, even though I'm certified in addiction medicine, I can't prescribe somebody methadone to take at home. It has to be through a licensed and regulated facility. Buprenorphine is the partial agonist that we use for treatment of opioid use disorder. The brand name of the mono product that is buprenorphine alone is Subutex. That's the way that people refer to it a lot is by calling it Subutex, but really it's buprenorphine alone. It's a partial opioid receptor agonist. It comes in buccal tablets, and so it has to be dissolved in the mouth, because if somebody takes it, swallows the pill, then it doesn't have very good absorption and it can cause nausea. It has kind of a bitter taste to it, and it's infrequently used outside of pregnancy, which we'll talk about in just a minute. Suboxone, which is Subutex plus naloxone, or buprenorphine plus naloxone, and Zubsolv are 2 of the more common forms of the buprenorphine plus naloxone medication. And so this is what's more frequently used outside of pregnancy, and now more frequently used in pregnancy as well. Suboxone comes in sublingual films that has a citrusy taste. Zubsolv has more of a minty taste. And the reason why this matters, what these taste like, is that people become pregnant and then they all of a sudden can get some pretty bad food aversions, taste, smell aversions, and something that they were able to tolerate before they might not be able to tolerate as well now. So I find that oftentimes Zubsolv is better tolerated in pregnancy because mint is something that sometimes actually helps with nausea, whereas the more bitter taste or the citrusy taste, some people can't handle those of Suboxone or Subutex. And so it's sometimes you have to change medication for that reason, because of their ability to tolerate the taste. But we'll talk in 1 second about why otherwise we actually don't recommend changing medications in pregnancy. So buprenorphine plus naloxone is used for diversion and misuse, for stopping diversion and misuse of the medication. Naloxone has no oral bioavailability. So if somebody's taking it correctly and they're using it buccally, sublingually, or even if they're swallowing it, they're actually not getting any of that naloxone in it at all. So it's having the same effect as the buprenorphine mono product if you're using it correctly. But if it's crushed and injected or snorted, then it can precipitate withdrawal, because naloxone is bioavailable in those routes of administration. And so the only purpose of naloxone is to prevent diversion and misuse. So there's a lot of misconception in the medical world and among patients themselves that Suboxone can't be used in pregnancy. And this is absolutely not true. So the mother study and the other earlier studies that were looking at partial agonists and buprenorphine in pregnancy did use the buprenorphine mono product. And they did that just because this is the way research works, that we use the most pure medication whenever we're we're studying something at first so that we can figure out the safety profile of that medication and not have to worry about any sort of, confounding factors. And so the initial studies were done with buprenorphine alone. And when those studies were done in the early 2000s, it actually was the recommendation if somebody was on Suboxone and they became pregnant to switch them to Subutex, or the mono product, buprenorphine mono product. But since those studies, there have been a lot of data that has been collected about people who are taking the buprenorphine plus naloxone product, and there doesn't seem to be any harm in pregnancy of naloxone, which makes sense biologically, because there's no oral or sublingual or buccal bioavailability of naloxone. So why would we expect it to be any different? So the recommendation now is, if somebody is on a medication prior to pregnancy that they're doing well with and they become pregnant, keep them on that same medication, because anytime you change anything about somebody's medication, you switch from one to another, is a time that they're open to becoming destabilized and returning to use, because you might not be adequately treating their symptoms of withdrawal. So the next myth that I want to talk about is that Subutex will not precipitate withdrawal. This is something that a lot of obstetricians seem to think. They think, oh, the product with naloxone in it, we can't give that because that can precipitate withdrawal. So we'll give the mono product that doesn't have naloxone and it won't precipitate withdrawal. And that thinking is incorrect. So it's not the naloxone that precipitates withdrawal in people that are on full opioid agonists. It's the fact that the buprenorphine is a partial opioid agonist. And so you're going from 100% expression of that receptor immediately to 50% expression of that receptor. So any buprenorphine product can precipitate withdrawal and needs to be used carefully in that sense, and think about the initiation and when and how you're initiating it. There's no difference between Subutex and Suboxone or Zubsolv or any of the dual products with buprenorphine and naloxone with their ability to precipitate withdrawal. And of course, we worry a bit more about precipitated withdrawal in pregnancy than we do outside of pregnancy, because not only is it decreased satisfaction of patients or their ability or their likelihood of continuing the medication, but it can cause stress for the baby as well. So this is just a visual showing you that the problem is going from the full opioid agonist to the partial agonist very quickly. And that's what precipitates withdrawal, not the naloxone. So I told you before that methadone and buprenorphine are both medications that we use in pregnancy. So one of the more common questions I get is, well, which one is better, buprenorphine or methadone? And the answer is whichever one the patient is going to take is better. So this is showing a meta-analysis that looked at the primary outcome of the person not using opioids at the time of delivery. So the person being only on their MOUD and not having returned to use of opioids at the time of delivery. And you can see that these boxes cross the number one. And if they cross this vertical line here, that means that there's no statistical difference. So the take home point here is that there's no statistical difference between methadone and buprenorphine in keeping people from using their illicit opioids. So either one of them is fine. It's whichever one the patient prefers. It is important for people who counsel patients about methadone to understand, particularly in our patient population in Baltimore, but anywhere that you are taking care of patients, that there is a very unfortunate history about the creation of methadone and the way that it was first marketed and recommended to patients. So methadone is the country's most regulated medication, which is wild because it's not the most harmful. Methadone was approved for opioid use disorder treatment in 1972, and the regulations surrounding it about how it could only be dispensed from certain facilities in certain places by certain people was really designed to limit the person's control over their daily routine. So these practices are open very early in the morning, and you have to come in physically every day to get your medication. And the whole purpose of that was literally to control people. And methadone clinics were placed in Black and brown communities with the expressed goal of trying to reduce crime. So it initially wasn't really actually a public health measure. It was a crime reduction measure, which is quite unfortunate because this is a medical problem, like we said before, and it should be really treated as a disease and not a moral failing or a crime. Buprenorphine was first approved in the early 2000s, and it really coincided with when the opioid epidemic started to spread after OxyContin was available and started to be prescribed all across the country in more rural areas and suburbs. And then it really became more of like a middle-class white problem. And when that started to happen is when buprenorphine was approved. And it was really looked at as a medication that was supposed to be available for people who didn't need the regulation that methadone required. And so people that were could be trusted more than people that were taking methadone, essentially. And so unfortunately, if you look at a map of the country and where buprenorphine is available, where methadone is available, and the racial makeup of the country, they overlap in a very disturbing way. And that Black and brown communities are much more likely to have access to methadone than buprenorphine. And white communities, particularly like suburban middle-class white areas, are much more likely to have access to buprenorphine. And so this obviously is not the way that we should be making any decisions about how people get medication, and everybody should have access to both and the ability to choose which one is best for them. So I did mention that there are full antagonists. Full antagonists to opioids include naloxone, which is used IM, IV, subcutaneous, or intranasally for reversal of overdose. So anybody that's been in Baltimore has probably seen the don'tdie.org campaign that is for everybody to have naloxone so that you can reverse somebody's overdose. Naltrexone is a longer acting, either PO or extended release intramuscular, or there's now some implants that can be placed to do long-term maintenance abstinence. And so it is a full opioid blocker. It does not help with withdrawal. What it does is decrease the person's benefit of taking any sort of opioids because it blocks the opioid and they won't feel any sort of difference. And so they don't bother to take it. It also prevents withdrawal in that way as well. It's not really recommended to start those things in pregnancy because somebody has to go through withdrawal to get to that point. And also they haven't really been that well. There's current studies going on about them in pregnancy, but they're not as of yet well studied. Medically supervised withdrawal, or quote unquote detox is usually what people call it, is not something that we recommend in pregnancy. Now, I certainly have had patients that I've helped through this if this is the only form of treatment that they will accept. But the reason that we don't recommend it is partly because withdrawal can be harmful in pregnancy, but more importantly, because addiction is a chronic disease, and with withdrawal or detox is really an acute treatment. And so the relapse rates are as high as 90%. And overdose deaths, when people do relapse after medically supervised withdrawal, or even unsupervised withdrawal, the overdose rates are much, much higher because their body has decreased their dependence. They go back to their former use and then they overdose. And also because, as I said before, in utero withdrawal is more harmful to a baby than withdrawal after delivery. And so the reason that most pregnant people tell me that they want to go through this during pregnancy is because they don't want their baby to have to withdraw after delivery. But that is something that is much more treatable and has less long-term concerns than withdrawal in utero. So what sort of specific considerations do we have to think of during prenatal care? What do people who are coming to prenatal care and have opioid use disorder, what special, sort of considerations do we have to have? So the biggest one is really dosing of their medication. So remember I said before that when I very clearly remember the first patient that I ever met on methadone in pregnancy when I was in medical school. And not only was I surprised that we were giving her opioids, we were also increasing the dose that we were giving to her, which just like blew my mind. It seemed so strange. I was like, isn't this more harmful to the baby to give it more? But actually, no, remembering going back to the point that I made that it's not actually the opioid that is the problem, it's the stability of the environment. And so it's very frequent that both buprenorphine and methadone are going to need to be increased during pregnancy, and that has to do with the physiology of pregnancy and the way that it's metabolized in the body. Partly with buprenorphine, it actually has to do with the pH of saliva and the way that it's absorbed as well. So there might actually be decreased absorption of buprenorphine, and then there is most certainly faster metabolism. And so this leads to two things. One is needing to increase doses often, and the other one is oftentimes needing to have twice daily dosing, because with buprenorphine and methadone, both, we think of them as once a day medication, but in pregnancy, oftentimes you need them more than once a day. So this is a study where they gave patients their full dose of buprenorphine in, I think they were in like 2 milligram strips. And then if you were getting 24 milligrams in a day, you would get 12 2 milligram strips. And they said, just take it whenever you feel like you need to keep yourself feeling like in a steady state and not in withdrawal. And then they measured to see how frequently people were taking it. And the most common dosing that people did when they did self-dosing was 3 times a day to feel stable during pregnancy. Unfortunately, most insurances will not pay for 3 times a day dosing. And so usually what we default to is twice a day dosing when people are having withdrawal symptoms. But the reason that I want everybody to know this is because if somebody's telling you that they're feeling withdrawal symptoms, it's important to figure out when they're starting to feel those withdrawal symptoms or cravings, because just increasing their once daily dosing might not actually touch those symptoms if they're feeling them in the evening or at night, or 12 to 18 hours after they took their first dose. And so instead of increasing their one-time dosing, my reflex is typically to try twice daily dosing and see how they do with that. And not everybody needs it. There's not an algorithm or a standard that you definitely need twice daily dosing, but it's definitely something that should be considered during pregnancy. And the same thing with methadone. Clearance increases in pregnancy, and so the dose oftentimes needs to be increased. And then frequently I will see pregnant people who their dose was increased, but then they're like somnolent or oversedated in the morning, but then they're still feeling withdrawal symptoms by the evening because it's faster metabolism. And so again, twice daily dosing or split dosing of methadone is really frequently needed. And I've had to speak to many methadone clinics around the area to get this approved for my patients. And I find that most people are very willing to approve it once, you really talk through it and explain that this is actually the recommendation during pregnancy. Another thing to know when you're taking care of pregnant people who have substance use disorders or opioid use disorder is that is usually not their only problem. About 2/3 have co-occurring mental health disorders. And the large majority of them have experienced either physical or sexual abuse in the past. About 60 to 80% have experienced past year intimate partner violence, and 80 to 95% smoke cigarettes, which is arguably tobacco is the most harmful substance during pregnancy. And so I think this is important, a way to frame, like when we look at outcomes of people that use opioids during pregnancy, we like to blame all of the negative outcomes on their opioid use, when really all of these co-occurring factors are as much, if not more, related to the negative outcomes in pregnancy. And so getting somebody stable on MOUD is, for their health and their baby's health, is very beneficial, but it also is just the first step in helping them work through all of the rest of these medical and psychosocial problems that are also likely to be affecting their health and their baby's health. Intrapartum management, when someone is in labor or we're monitoring their fetus during pregnancy, the recommendation during labor is to continue their MOUD. Neuraxial analgesia can be used, so they can get epidural analgesia. IV pain medication can be used, but it needs to be with a full agonist, so morphine or Dilaudid. Stadol or butorphanol is something that is often used during labor for pain management, but it's a partial agonist. And so if it's used with somebody who is on methadone, it will precipitate withdrawal, because again, they're going from a full agonist to a partial agonist. Stadol is a similar kind of mechanism, physiological mechanism of buprenorphine. And so it should not be used on people who are on MOUD during pregnancy or during labor, because you can precipitate withdrawal. One thing that I frequently see is that people that's not the way I should say it, that sounds malicious. People tend to blame some things that can happen during labor or pregnancy on MOUD and think like, oh, this abnormality that I'm seeing, well, that's okay because she's on methadone, like that's the reason for it. So there was a study that was done where they looked at fetal monitoring prior to and after dosing of someone's buprenorphine and methadone. So these were in-person controls. Like they measured the same woman pre-dose, and then they dosed her, and then they measured these things in the baby post-dose. And they found that buprenorphine did not really have any appreciable change on the fetal heart rate. Methadone did cause it to decrease by about 4 to 5 beats per minute, but not to the point where it was such a low baseline that it was out of the range of normal. There were fewer accelerations, fetal heart rate accelerations with both buprenorphine and methadone, but as you can see, they were still present. They were just less frequent when a person was on MOUD with either buprenorphine or methadone. And then the likelihood of having a non-reactive NST or non-stress test was higher with methadone after dosing, which of course has to do with is related to the last slide of less frequent fetal heart rate accelerations. And then you were a little more likely to get a biophysical profile less than 10 with methadone, but not so much with buprenorphine. But still, the average was 8, which is considered to be a normal biophysical profile, 8 out of 10. And so if you're seeing somebody who has a very low baseline or no variability or no accelerations or having decelerations or their biophysical profile is low, then those things really should be evaluated specifically in the same way that you would evaluate anybody else. It shouldn't be blamed on their MOUD. I don't have a slide in here about it because there's not as pretty pictures in this study that studied this, but the beat to beat variability should remain the same. And so the likelihood of having moderate variability and the ability to rely on moderate variability as a positive predictive factor of the fetal well-being is the same with people who are on MOUD. So any change in fetal heart rate should be investigated. Postpartum management, again, just like with intrapartum management, MOUD should be continued postpartum. You should add a full opioid agonist like oxycodone, morphine, or Dilaudid as needed for pain. It's also possible to do additional dosing of buprenorphine. For people who are on buprenorphine, you can give them QID smaller doses. So let's say somebody was taking 12 milligrams in the morning for their opioid use disorder. You can give them 2 to 4 milligrams 4 times a day for pain management. And that can be helpful, particularly for people who may have previously had a use disorder and used oxycodone or some of these other prescription medications. They may not be comfortable taking those medications. It may be a trigger for them. And so then changing their buprenorphine or adding additional buprenorphine can be helpful. Stopping buprenorphine to give full agonist for pain is totally unnecessary. This is something that used to be taught, I think, for acute pain management, that you should stop their partial agonist and give them a full agonist, but that is definitely not necessary. It can lead to destabilization of the patient and increase their likelihood of return to use. And after somebody delivers, it should be discussed in advance what medications they're comfortable taking home, if they have family members or other support people who can help monitor their medication so that they don't feel triggered by taking home a bottle of oxycodone or even having access to that medication. Oftentimes I'll have a trusted support person who controls the medication, like keeps that medication and just dispenses it to them as it's prescribed. This is showing the benefit of buprenorphine for pain. And so one of the very nice things about buprenorphine is that it's rather hard to overdose on it. And so when people overdose on opioids, one of the things that happens is that they have respiratory depression and they stop breathing. But this is showing with higher doses of buprenorphine, there's not any appreciable respiratory depression, but there is improvement in pain management. So if people on this webinar are buprenorphine prescribers, you probably learned that there's a ceiling effect of buprenorphine as far as withdrawal management goes. Like once you get above 32 milligrams, probably there's not really a benefit of for withdrawal anymore, but there is pain management improvement with continued or smaller, more frequent doses of buprenorphine. So as I said previously, it is not recommended to stop buprenorphine and give a full agonist for pain management. This is something that used to be taught, and still a lot of people think like, oh, they're on a partial agonist that's going to block the full opioid and they're not going to get any pain relief. But that actually is not true at all. This is a study that showed people who were using buprenorphine and either stopped their buprenorphine or continued their buprenorphine and then got PCAs, like IV patient-controlled morphine. And the people whose buprenorphine were stopped, or buprenorphine or methadone were stopped, actually needed much higher doses of morphine than those who were continued on their maintenance MOUD. And so the recommendation categorically is to continue a person's MOUD, whether it be methadone or buprenorphine, and then give them full opioid agonists on top of that to manage their pain. When we're talking about pain management, hyperalgesia is something that everyone should be familiar with. So hyperalgesia is a state of nociceptive sensitization caused by chronic exposure to opioids. And so probably everybody has seen before somebody who is living with opioid use disorder, and they've been using opioids chronically, and then they have very what appears to be very exaggerated responses to painful stimuli, so placing an IV or drawing blood or any other sort of intervention that might be viewed as slightly painful to another person, or their post-operative pain is out of proportion to what you would expect. And this is often viewed by providers as someone who is drug seeking, and they're just trying to get more opioids. But it actually is a physiologic response to this sort of attenuation of the opioid receptors, and it's reproducible in laboratory animals who do not have any secondary gain of trying to ask for opioids. Like it is definitely something that has been proven to be a physiologic response. And so the treatment for it is to give people more opioids until you're able to control their pain. Because one of the biggest triggers for relapse is uncontrolled pain. I've had many people tell me that they left the hospital and they felt like the providers were all just sort of ignoring their pain and acting like they were exaggerating it, and didn't want to give them any opioids because they had a history of a use disorder. And then they leave and they're in terrible pain. And they think, well, I mean, I know what's going to treat this pain, that I can just use illicit opioids. And it wasn't necessarily psychologically that they were intending to go back to use, but that was the only thing that they knew that could control their pain, because the medical community kind of failed them. So continuation of MOUD postpartum is absolutely categorically recommended. A lot of people will say that they want to wean their MOUD after pregnancy, and really you need to look into what the reasons are for wanting to do that. So this is showing how the unfortunate decrease in MOUD use after pregnancy, and the likelihood that someone's going to continue use of their MOUD after pregnancy is directly related to how long they were on it, either before or during pregnancy. So I start talking to people about this from their very first visit, that this is not something that I am only recommending you be on because you're pregnant. This is something that is really for your long-term health and recovery. And one of the big reasons that I tell them straight up, and also the reason that I recommend this is because that everybody recommends this is because the risk of overdose is actually highest in the year postpartum. So looking at this graph, you can see that during pregnancy is actually not the time at all that people are the most likely to overdose. It's in that postpartum period. And this really lasts up to 12 months postpartum that people are likely to overdose. And that's really what's driving these overdose and death by opioid numbers, is not during pregnancy, it's in the postpartum period. So the very strong recommendation is to continue MOUD in the postpartum period, because again, addiction is a chronic illness and it requires a long-term treatment. The doses don't typically need to be decreased immediately postpartum. We talked about the physiology of pregnancy and how that oftentimes means we need to increase the dose during pregnancy, but strangely, it doesn't mean that you need to immediately decrease it in the postpartum period. It should really be viewed as something that is individualized, and just, kind of monitor how the patient is doing. Oftentimes, I think people want to decrease the medication postpartum because it can increase the likelihood of somebody being somnolent or oversedated, and we're very worried about how that's going to affect their care of the baby, which is a very real concern. But I think that postpartum moms need to be treated the same way that other postpartum moms who use opioids or on MOUD should be treated the same way any other postpartum mom is treated, which is look at the person in the sense of like, you just had a new baby, you're exhausted. So if you seem very tired when you're in the office with me and you have bags under your eyes and like are having trouble completing full sentences, is that because of your MOUD, or is that because you didn't get any sleep last night because you've been up with your baby all night? So take all of that into consideration. For those who do desire weaning, my first question is always why. Do you have this misconception that you're now addicted to this medication? Is it because you want to return to use? Is it because it's too challenging to stay in treatment and we require you to come in too frequently, or there's barriers, transportation barriers, childcare barriers, those type of things? Is it because other people, support people, partners, family, other doctors, the court system is trying to tell you to come off of this medication? And I've had that happen to people, that they go to court for the DSS court for custody of their baby, and they're like, well, you're still on this medication, you need to come off of it, which is outrageous. So figuring out what their motivation is really important. And what I usually tell people is, give me a year postpartum. I understand that like thinking about being on this medication for the rest of your life might feel overwhelming, but let's not think about the next 50 years. Let's just think about the next 12 months. And right now there are too many physical, hormonal, changes that are happening in your body. You don't need another thing to cause more stress to your body right now. And so let's just get through this first year, and then we'll reevaluate. And most people, when you put it in that way, are more likely to agree to continue. Postpartum contraception for people with opioid use disorder is unfortunately underutilized, and that's probably because there's not enough access to it. And so this was a study of all Pennsylvania Medicaid recipients who were on MOUD, and 75% of them received no method of contraception after delivery, and only 7% of them received a highly effective method, and approximately 20% of them had short interval pregnancies. So this is something that needs to be addressed with all postpartum people, and particularly needs to be addressed and accessible to postpartum people with opioid use disorder. But I will say, with the caveat that we need to be careful about contraceptive coercion. And so we should not address it in the sense of, you have a use disorder, how are we going to prevent you from being pregnant, as those are like directly related things, right? Instead, it should be, here's the access to the contraception. This is why I don't recommend pregnancy within a year for any person, not, irrespective of your opioid use disorder. But you don't want to seem as though you're shaming the person and saying, because you have an opioid use disorder, you shouldn't ever get pregnant again. So usually I frame it with people as, so when is the next time you would like to be pregnant? And some people are like, oh my God, never, obviously. And then other people say, well, I think I want another couple years before I want a kid. And so then we talk about how we're going to meet that shared goal together, as opposed to framing it as, you just had a baby and you're on methadone, how are we going to prevent that from happening again? Which is the way that, even that, although no one's saying it that way, that's the way that it gets received by a lot of patients, because they have a lot of shame and guilt about their circumstances. And there's a lot of emotions that come up in the postpartum period if their baby is going through neonatal opioid withdrawal, or, just from general access to medical care, they oftentimes feel shame and guilt. So breastfeeding is categorically recommended in people who are on MOUD. Both methadone and buprenorphine are excreted in the breast milk, but this slide is showing that they're excreted at exponentially lower doses than the mother is taking. And so the doses of methadone ingested by babies ranged from 0.006 milligrams to 0.084 milligrams per day, as compared to, the mom might be on 100 milligrams of methadone. The concentration really didn't seem related to the maternal dose, but the point is that it's incredibly low, and it doesn't cause any problems that have ever been documented for the babies. It should be considered, though, that for any person, that particularly people on MOUD, that breastfeeding can be stressful. And so I talk to my patients about the benefits of breastfeeding, but then also that I don't want them to feel pressured to breastfeed if it's not what's going to work best for them and their recovery. And so as anybody who's ever known a breastfeeding person knows, it can be stressful because of the demands on schedule. Babies want to feed all through the night, unpredictable and irregular schedules, and it may not allow the person to get the time and space that they need for their recovery. And so I just talk to people very honestly about this and say, there are some benefits of breastfeeding, and I'm very pro breastfeeding if that's what you choose, but I don't want you ever to feel pressured into it or shamed if you don't breastfeed. And also, it is not worth the benefits if it is going to jeopardize your recovery. So if you feel like you're up all night and it's affecting your mood, it's making you have cravings and think about using again, then absolutely breastfeeding is not the right thing, because what's going to be best and safest for the baby is a parent who's able to maintain recovery, not somebody who's breastfeeding. Neonatal opioid withdrawal syndrome is something that all of my patients always ask me about and worry about. And I think it's very important to understand it so that we can give people anticipatory guidance, because this, again, is something that causes a lot of emotional turmoil for people after delivery. And the better prepared they are, the more able they're going to be to stay in recovery. So NOWS is an expected and treatable condition among infants exposed to opioids in utero. It should not be viewed as a negative consequence or as a bad outcome of a pregnancy. It's something that we expect if somebody is on opioids during pregnancy. When it's treated appropriately, there's no evidence that NOW has negative long-term consequences. Counseling regarding NOWS is necessary during the antenatal period, and you really should know your hospital policies regarding monitoring, because one of the biggest things that causes friction for my patients postpartum is that our policy is that we typically monitor babies for 5 days postpartum for NOWS, whereas moms are usually discharged after 2 or 3 days, and they get very upset about the idea of being discharged without their baby, understandably. And so we have worked to have a hospital policy where if a baby remains in the newborn nursery and the mother is discharged, she can stay in her hospital room with that baby, because part of the treatment of NOWS is skin to skin and being in a low stimulation environment and with the parent. And so we view that room as the postpartum room, both for mom and baby, and that room stays their room until the baby is discharged, even if the mom is. But then this includes counseling about things like bringing your own medication and understanding that once you're discharged, you'll be responsible for your own medication and food and things like that. But they should be encouraged to stay with their baby. Infant withdrawal usually begins within a few days after the baby is born. It can last for up to 2 to 4 weeks after birth. Reducing the dose of MOUD before delivery does not reduce the likelihood of NOWS or the severity. And so this is a common misconception that patients are like, well, I'm in my 3rd trimester now, I want to start going down on my medication, which is absolutely wrong, because what that's going to do is increase the likelihood that they're going to return to use, because it's going to destabilize them and increase their risk of withdrawal. It's going to expose the baby to in utero withdrawal, and it's not going to decrease the risk of NOWS. And so I tell them that if your concern is about neonatal opioid withdrawal, that is something that we'll treat and manage once the baby is out. But you decreasing your medication dose is not going to improve that or decrease the likelihood that that's going to happen. But what will decrease the likelihood that it's going to happen and the severity is smoking cessation. So for people who are on MOUD and using cigarettes, I tell them, don't worry about your use of methadone or buprenorphine. You don't have to change that. But if you're worried about NOWS, if you're able to stop smoking, that's what's going to have the biggest effect on the baby's withdrawal. And so then kind of refocusing them on that, which is going to improve their outcomes. So this is showing methadone versus buprenorphine and the risk of NOWS. And so the summary of this slide, basically, I think is on the next slide, is that the length of stay and total dose of morphine needed for NOWS are slightly less with buprenorphine than with methadone. But people who are on buprenorphine shouldn't be counseled that their babies don't have a chance of withdrawal, because they do. It's just that the withdrawal is slightly less likely to need medication or as much medication and slightly shorter time period than with methadone. And the dose of buprenorphine and methadone, again, are not related to the severity or length of treatment for NOWS. So this is what I was talking about before, is that one of the treatments of NOWS is skin to skin, or rooming and just being near the birth parent or caregiver. And so this is a study that showed in a hospital system, when they started having rooming in with the birth parent, the baby and the birth parent, within 2 years, they cut their need for medical treatment of neonatal opioid withdrawal in half. So only about half as many babies needed morphine treatment for opioid use for NOWS after they started doing standard rooming in. It decreased from 46% to 27% of babies that needed medication treatment. So this is just showing that this low stimulation environment, rooming in with mom, skin to skin, is something that really improves the outcomes for babies. And then again, I mentioned this before, but tobacco smoking and NOWS, people who use tobacco during pregnancy the babies have increased risk of need for morphine treatment, increased length of hospital stay, and longer treatment course. And this actually is related to dosing. So I told you that the dosing of methadone or buprenorphine is not related to NOWS, but the amount of cigarettes they smoke is related to NOWS. And so the ideal, of course, is complete smoking cessation, but even if they cut back from a full pack to a half a pack a day, that's going to have some improvement on NOWS. And so this is just another tool in your toolkit to help counsel people about the importance of smoking cessation during pregnancy. So in summary, opioid use in pregnancy is common and treatable. MOUD is standard of care in pregnancy. Methadone and buprenorphine plus or minus naloxone are safe and effective. MOUD should be continued postpartum and at appropriate pain medications. Continued support in the postpartum period is critical. So it's very common that we're seeing people weekly in the last month of pregnancy, and then they deliver and they're not seen back for another 6 weeks, and then that's it. And they come back for a year postpartum. And that is absolutely not an appropriate schedule for people who are on MOUD and have an opioid use disorder. They should be seen more frequently in the postpartum period. And then breastfeeding should be encouraged. NOWS is an expected and treatable sequelae of opioid exposure. It shouldn't be viewed as a negative outcome. Severity of NOWS is not related to the dose of MOED. Nicotine use increases the severity of length of NOWS, and rooming in should be considered part of treatment of NOWS, and parent and child separation should be limited as much as possible. And anticipatory guidance should be provided to all pregnant people to improve the likelihood of maintaining recovery and decreasing stress and stigma in the postpartum period. And then again, just a reminder, this was Max for Moms talk, and we are available for both. Obviously, you're here, you signed up for this, or we're available for educational purposes. And then also anytime that you want to email us or call the warm line, we would love to talk to you all. And that's all.
Thank you, Dr. Mark. I encouraged everyone to write some questions into the chat. I haven't seen any yet. We have had some positive feedback so far. Someone wrote, this presentation should be required for every labor, delivery, and postpartum nurse. So we did just get a question. And the question is, I work with neonates in the NICU and nursery. I noted more withdrawal symptoms with methadone or buprenorphine treated moms than illicit drugs. Do you know why?
Well, I would say it depends a bit on, it's circumstantial, right? And so there are so many things that go into whether or not a baby is going to experience withdrawal. And in general, studies don't necessarily show that that people on MOUD are going to have longer or worse, babies are going to have longer or worse withdrawal, but there certainly is a genetic component to it. That we don't fully understand yet. And so some babies who are on incredibly high doses of either illicit drugs or methadone or buprenorphine don't experience any withdrawal. And then some babies that were exposed to much lower doses experience very severe withdrawal. And so this is why we say that the dose isn't actually the direct factor. And there are currently studies going on to try to figure out what the genetic factors are. And it's the same with moms too, right? Or any people that are using opioids chronically. I'm sure you've noticed, and if you have patients who have opioid use disorder, some of them experience very bad withdrawal when they don't use for a short period of time, and some of them really don't. And so there's just a lot we don't really know about it, honestly.
Great, thank you. I'm not seeing any other questions right now. We do still have a few minutes, so please feel free to write those in. I'll just take this time to remind you, if you would like some doTERRA bags, which are used for safe drug disposal that you can hand out to your patients, please contact Max for Moms. We do have a limited supply, and we are happy to send those over. But Dr. Mark is a great resource to have online with us live right now, so I do encourage you to ask any other questions you may have about this topic. Someone else said, thank you for this information regarding pain management postpartum. Okay, the next question is, currently working with a pregnant mom who continues to use marijuana and desires to quit. What programs do you recommend?
It's a good question. So the thing that is easier or more satisfying about opioid use disorder is that we do have a medication that we can prescribe to people to prevent their withdrawal and symptoms. Marijuana sometimes can be more challenging in that sense, that the treatment for it is really behavioral. But I actually gave a whole other hour webinar on cannabis use, but I'll give you my very brief version of the answer, which is my first question to people who are using marijuana during pregnancy is always, why? What is the benefit that you're getting from it? Because a lot of people will tell you that they're treating some sort of symptom, right? It's for helping them with their appetite or for sleep problems or anxiety. And so figuring out if they're sort of self-treating some underlying symptom and helping them with that. Otherwise, there are referring them to addiction counseling to do cognitive behavioral therapy is very helpful for people who it is more of a, I don't like the term recreational, but more of like non-medical use, which usually in those circumstances, people will say it's for like stress relief or something the same way kind of that people look at alcohol. And so referring them for cognitive behavioral therapy, I think is very important too, because I think a lot of times we as OB/GYN providers just tell people, well, don't use marijuana, but we don't really provide all that much support. And like we tell them the bad stuff about it, but we don't really help with their cessation of it. And so, oh, thank you for putting that in the chat from to my previous webinar about cannabis use. But yeah, referring to addiction therapy and trying to treat any underlying thing. And then the other thing that is in that webinar as well is that a very under-recognized fact is that cannabis can have some physical dependence, and so there are withdrawal symptoms from it. And so sometimes people try to stop using it abruptly, and they have these, like, they're not able to sleep, they don't have an appetite, they have other, sort of like mood disturbances and things like that. But if you can pinpoint those and figure out that they are actually withdrawal symptoms, supportive treatment for a week or two, and just telling them you're not always going to feel like this. This is just from your body getting used to not having the marijuana anymore. And in a week or two, you're going to feel much better. A lot of times that's helpful for people because they stop using, they feel terrible, and they're like, well, I guess I have to go back to use. So explaining marijuana withdrawal syndrome, I think, is helpful too.
Great, thank you. Let me make sure I didn't miss any, but I'm seeing another question here. Can drug exposure, methadone, or illicit substances, including cocaine, cause mental health disorders in children as they get older? For example, ADHD, anxiety, or depression?
So that is a super complicated answer. And the short answer is that we don't think that it directly causes those disorders. It can cause, particularly cocaine can cause pregnancy problems with like blood flow. It can cause placental abruption and things, and those things can kind of contribute to that. But the reason that this is so incredibly hard to study is that people, adults who are adolescents, whatever, like full-grown people who are going to become pregnant, who have these underlying mental health disorders, depression, anxiety, ADHD, bipolar disorder, all of those are more likely to use drugs to begin with. And so then the question is this actually just a genetic correlation that mom had ADHD and then she sort of self-medicated with a stimulant, an illicit stimulant, and now her baby has ADHD, like grows up to have ADHD? Is that because of the in utero exposure to whatever drug she was using, or is that because whatever genetic thing made her more predisposed to drug use and now causes her baby to also have that? So it's very complicated. But there is some possibility that chronic exposure to these drugs may cause some difference in the development of the fetal brain. That being said, we prescribe opioids for people during pregnancy. So not even thinking about like opioid use disorder, just pain management and other reasons that people may have need for opioids during pregnancy, we prescribe them, and we tend to believe that that's relatively safe. And so I think with opioids specifically, there's much less concern about like I said, the opioid itself, and much more concern about the surrounding behaviors and stability of the environment. So that was a long answer to a short question. The short answer is we don't know 100%. We probably never will know 100%, but there's probably more of a correlation than there is a causation between those things.
Awesome. Thank you so much. I'm not seeing any other questions right now, but I did put a link to our previously recorded webinars. That will also be where this recording will be available within 1 business week. I'll also try to include it when I send out your certificates or any other follow-up messaging. If there are any other questions, we do have 2 more minutes, so definitely get those in. But please also keep in mind that you can always be connected to Dr. Mark when you call our warm line, or if you join our Max for Moms Echo, and I'll put that information into the chat. If you're not familiar with our Echo cohort, it is used as a time for an all teach, all learn method, so you can present cases from your own practice load. And then the group will help you walk through the best way to treat that patient, give recommendations for care, and that is accompanied by a didactic presentation from our expert consultants. So definitely sign up for that if you have not already. Dr. Mark, I'm not seeing any other questions in the chat, so thank you for your time today. I think that was a perfectly timed presentation. I'm sure you could have talked about this topic all day, so we really appreciate it. And thanks everyone for being online.
Thank you.